Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name's Marc Ryan, and it's a pleasure to be hosting. And thanks to everyone for listening in. As I always do, I'll start off just very briefly with an overview of the healthcarelabyrinth.com website. Basically, we have three areas to go to each day for the health news of the day. First of all, the news feed, which is published weekdays daily. And I give you a summation and some editorializing perhaps on the news of the day. It saves you time. I peruse about 24 websites and I summarize what I think is the most important news of the day in the health plan and the general healthcare world. So the newsfeed tab at healthcarelabyrinth.com for the newsfeed. We publish a blog twice a week on topics, and that is available at the blog tab at healthcarelabyrinth.com. And last, the podcast. We publish the podcast weekly at the podcast tab on healthcarelabyrinth.com. And we're also on all leading podcast sites and applications now. It took us a little while to get up and running on all of them out there, but pretty much all of them are covered. A couple are missing, but we're working through those issues as well. So let's get to the topic of today's podcast, and it is sort of in response to a couple of blogs I've written related to the status of Medicare Advantage. There's a lot of news right now out there about investor relations calls and drops in healthcare stocks, very much tied to what's happening in Medicare Advantage. And one executive sort of had a bit of a dire admonition, I'd say, to not only regulators, but to the public at large about what was happening in MA. So let's get into the topic then. So what are some of the trends out there in MA? Number one, there's a bit of a MA rate crunch happening out there. So back earlier in the decade, say 22 and 23, we saw some very big trends in MA rates. And that really drove benefits and expansion around the country. And we'll talk a little more about that later. But in 24, the final rate increases and the just announced preliminary 25 rate increase is much, much lower. I would characterize these as roughly flat rate increases, or perhaps even a slight negative. Now, some critics would argue if you factor in risk score trends, it's actually a positive revenue trend. Others, like MA plans, would argue you can't factor in risk score trends because at least part of that is tied to risks identified in the population that will generate additional expenses. But nonetheless, in a general sense, there's a rate crunch. Generous revenue, not tied just to risk score trends, was occurring earlier, but in 24 and 25, it looks like rates, not counting risk score trends, are relatively flat. Now, why did this occur? Well, by and large, we see slightly lower effective growth rates in the fee-for-service program than before, but the biggest part of that was the phase-in of a fairly controversial new risk adjustment model. It is being phased in about 1/3 in 24, 1/3 in 25, and then it'll be fully in place in 26. But this model tends to take a great deal of revenue out of the system. My prediction is it could be up to 7% over the 3 years. And this model does two things. It migrates from ICD-9 to ICD-10, so that has some impact in general on certain revenue. But more importantly, built into the model was essentially retirement of certain diagnoses or clusters within the risk adjustment formula that would basically generate revenue to the plans. And this was done, they say, to sort of prevent overcoding. So that new risk adjustment formula tied to lower trends overall is leading to that cash crunch in terms of base rate increases for MA in 24, and the same will occur in 25. Next, we are also seeing significant medical expense rise. This is primarily occurring, it appears, in the Medicare Advantage world, but we may also see it in other lines of business as well. Why is it appearing in the MA world first? Well, it is the sickest cohort. It has aged Americans and disabled Americans. So it stands to reason that if utilization increases post-COVID pandemic are going to start to show up, they would largely show up in MA plans first. We are seeing that in the case, for example, of Humana, which is largely focused on Medicare Advantage. And they announced some news regarding their medical expense recently. We'll get a little more into that. We are also seeing at United, the other very large Medicare Advantage provider in the country as well. So we can see some medical expense rising too. We are also seeing major star troubles. And in the case of star, I've published a blog on this, but the star downturn really began in 2023 and continues in 2024 for star measurement. In many ways, the drops are a bit artificial. What do I mean by that? Well, during COVID, especially in star 2022 year, a lot of flexibilities were introduced by CMS to allow plans to rely on prior year history and things like that. So we, from say 2020 to 2022, saw some really artificial increases in star by the industry and by MA plans. And now that regular calculations are back in force in 23 and now in 24, we're starting to see star return to where it was before, but also drop a bit. And that's a bit of a troubling sign out there. We are seeing plans struggle with highly weighted star satisfaction measures. We're seeing plans battle low star scores in the area of medication adherence. And we're also seeing plans battle low star scores in what I call the complex clinical measures, things like plan all-cause readmissions, transition of care, and follow-up after emergency department visit for people with multiple high-risk chronic conditions. So these complex measures are struggling as well. And what does that do to health plans? Well, as everyone knows, if you're 4-star or greater, on average, you are given a 5% bonus in the rate. So if rates are already going down and you're not obtaining or losing that extra star bonus revenue, you are very much put at a disadvantage in the market. And lastly, let's talk a little bit about the regulatory front. Well, there's been a series of regulatory changes that are very controversial that are also being placed on MA plans too. Number one, we have a controversial risk adjustment data validation rule that came in 24. It is being challenged by Humana on due process and regulatory filing grounds and things like that. But what this RADV rule does is it basically says that the federal government can come in, audit you on a sample of a given year's risk adjustment filings. If a plan cannot produce medical documentation, medical record documentation is a better way of saying it, for the filed risk adjustment diagnoses, the results of that sample could be extrapolated across the entirety of the revenue for the health plan at a very, very large fine levied. Again, Humana in particular is challenging the rule. We may see some other friend of the court or other independent lawsuits by health plans. But basically, Humana is arguing, number one, you can't really have a rule retroactively. Number two, there are some fundamental flaws related to how you're approaching this sampling and extrapolation, because adjustments aren't being made for what's happening in the fee-for-service world as well, as an example. And again, lastly, some of the rule filing issues that they're going after. So that is in courts, and that could be decided at least at a lower court sometime in 24. There's also brand new prior authorization rule, which I have blogged about and I've talked about as being something that will be very injurious to MA plans, but really to the program as a whole and ultimately enrollees. And I'll get more into that later. But what this prior authorization rule change does is it basically limits MA plans to using the fee-for-service program's evidence-based criteria, which are known as national coverage determinations and local coverage determinations. Now, I've always made the case that these coverage criteria are really not appropriate. Number one, they are really meant to be applied in a post-service claim decision sense. Are you going to approve a claim in the fee-for-service program to a provider? So number one, it's a little bit backward compared to upfront prior authorization. But number two, I also believe that the NCD and LCD criteria are not really appropriate. Frankly, there is waste, fraud, and abuse in the fee-for-service program. There's a need to rein in the provision of certain services, especially in admissions to inpatient hospital, which is often abused by hospitals. And so by applying this rule that says plans can by and large only use the fee-for-service NCD and LCD criteria, you will see dramatic increases in medical expense costs over time. And there's some evidence that that's already occurring. There are a series of other interoperability rules, for example, that tighten prior auth timeframes. There is other program audit scrutiny that is occurring. There's going to be oversight of supplemental benefits, new health equity requirements, and other changes that will challenge health plans as well. But taken in totality, what essentially is happening is huge and vigorous oversight over Medicare Advantage. And I would make the case that Medicare Advantage is perhaps the greatest accountable and most overseen area of healthcare in the nation already. And largely because MA has now reached 50% of all Medicare beneficiaries, and that providers and advocates have gone on an aggressive lawmaker campaign to limit prior authorization and things like that, we're seeing even more attention to MA and more regulation compounding what is already a very strict regime. What's interesting is despite some of this out there, we have seen still very strong enrollment in the program. My last podcast and a blog that I did recently, I had predicted that we would have yet another slowdown and have some headwinds in the industry in terms of growth. There would still be growth, but they might have a hard time hitting sort of a 6 or 7% growth rate. Well, in truth, the growth rate was higher than that. It was well into the 8s. And despite some large plans like United and Humana forecasting that they would, have fairly conservative growth in the program, which to some degree came true in the open enrollment season, by and large, overall, the industry and even most of the top players did very well in terms of an enrollment growth. And we're going to get back to why enrollment will still continue, even though there may be challenges in MA as a whole, given what I've just outlined. So, as I said, some readers of my blogs and just readers of the internet in general contacted me and said, hey, listen, some of these headlines out there about what's occurring in MA are very troubling. Is MA in trouble? The boom may be over, right? That makes sense. Stocks were flying high. Enrollment was growing very, very large. And rate increases were high. And so stocks were flying high in the MA world. But more recently, stocks have taken a hit. And many of these readers of my blogs and listeners said, what exactly is happening? Are we going to see a collapse of MA somehow? Or are we going to see just sort of an adjustment down from the boom that we've seen most recently? And this really started because of United Healthcare and Humana's investor relations quarterly conferences that were being held by a conference call recently. Now, we will hear more of these coming up. So this podcast is being taped before some of those other ones, but I think you'll see some of the same themes. So United Healthcare first reported that they were seeing unexpected medical expense increases, and most of that was occurring in their Medicare Advantage world. They are the largest provider of Medicare Advantage out there in the country. And so they first reported this, and they basically said that much of this was unexpected. It was beyond what their actuaries had thought would occur. Next on board was Humana. And Humana did an early filing with the SEC to talk about some of these trends in Q4 of 2023 and what 2024 might look like. And then in their investor conference about a week or so later, Humana basically realigned their forecast not only for 2023, but for 24 and beyond because of the medical expense uptick that was unexpected for them as well. Elevance Health also had their conference and did not report medical expense differences from their assumptions, but they did report that there was some higher medical expense in MA as well. So we have this body of evidence that medical expense or utilization is increasing in the MA world. And, that is what has spooked investors. At various points in time, whether it was after United or after Humana, we have seen stock prices drop fairly dramatically in the insurance world, especially for those stocks that are really tied heavily to the Medicare Advantage world. And why are we seeing these increases in medical costs? Well, as I pointed out a little bit earlier, utilization is slowly returning to normal in the healthcare industry post the COVID pandemic. Second, inflation is taking root again in the healthcare world. It was a lot slower than what inflation was in the general world, but it is forecasted to be what I call moderately aggressive. So we're starting to see, upticks in medical expense because of not only utilization, but also because of inflation. And third, plans are also seeing some new COVID-related costs. COVID is again on the uptick, and hospitalizations, especially among vulnerable populations, is moving up. And fourth, I would point out that high drug prices, especially in the specialty and medical area, continue to take a big bite out of insured's pocketbooks. While drug prices might be called fairly moderate in terms of increases lately, we are still seeing fairly significant trends in very high cost drug areas, new introductions, or inflationary increase in these specialty and medical drug areas. And as again, I'll point out is that while we see this utilization increase, we're seeing major cost containment areas being cut off, most notably this prior authorization change related to not using outside criteria at MA health plans, but having to largely use just the national coverage determination and local coverage determination criteria in the program. And so let's talk a little more about Humana, because Humana is the one that sort of set off much of the worry in the industry. United a little bit, but it was really what was said by Humana's CEO, Bruce Broussard. So, I believe Bruce Broussard is one of the most gifted and brilliant guys in healthcare today. So I really listen to what he says. He's actually retiring from Humana after leading Humana over more than a decade. He'll retire later this year. And again, I think he understands MA better than anyone out there. And at the recent conference call, I'm going to read a quote from Broussard, but there's a couple of thoughts about what Broussard was doing at this conference call. One, some people would argue that he accidentally went too far in his statements on MA and what was occurring in the industry. But others, and I tend to agree with the others, might say that it was Broussard's intended bold swan song admonition to Capitol Hill, CMS, and others that, a lot of politics and short-sighted policy is entering the picture here, and that this will end up backfiring on not only the MA industry, but the 30 million plus who rely on MA every day for their health care. And also, he might also have been trying to fundamentally reset investors' expectations about MA. I would argue that some of this downturn in stock is related very much to an investor frenzy, right? Investors and analysts were talking about how great MA was going, but there were clear warning signs out there that there were changes that were occurring, and they simply missed it. You can't argue that it was just the MA companies that missed it or the insurers that missed it, but that investors and analysts missed it as well. So I think what Broussard did was fairly deliberate, and I think he actually did a great public service. So what did he actually say? So at this Humana investor conference call, Broussard predicted that the entire industry, the MA industry, may have to make some similar pricing adjustments to what Humana did for 2024, and that the industry and Humana may actually have to continue to do this in the future because of these utilization trends and regulatory changes. Let me sort of quote what he did say. He stated, quote, "I think the whole industry will possibly reprice. I don't know how the industry will take this kind of increase in utilization along with regulatory changes that will persist in 2025 and 2026, end quote. So a pretty strong statement, especially to investors in a heavy regulated SEC type of environment. But again, I think he was right. So we saw this upsurge in medical expenses at Humana first for a couple of reasons. Again, as I noted, it's primarily an MA company. While United also saw it, it was a little more softened in terms of the impact because their revenue is cushioned and their costs are cushioned by other insurance lives in a very large Optum service subsidiary. It also appears that Humana may have done the right thing and readied for the new prior authorization limitations. Humana said on the conference call that part of that medical expense increase was related to upticks in inpatient days and lower observation days. Well, one of the changes that will occur in the prior auth rule is the NCDs and LCDs are pretty prescriptive about allowing more inpatient admissions than not. Traditionally, MA plans have wanted to see whether somebody really has to go into an inpatient world by having outpatient observation for a period of time. Many people end up being discharged and going back, but in the fee-for-service world, IP admissions are much greater. And so Humana referenced the fact that the so-called two-midnight rule, which is related to observation versus inpatient stays, had a notable impact on their QFAR costs of inpatient. And so it's very possible that Humana may have implemented this 1/1/24 rule early, and we're already seeing some of the effects of the limitation on prior authorization. Let's talk a little bit about what Broussard meant about repricing. Well, it's a fairly complicated issue, but here's my best effort to explain it here. The truth is that MA plans take many liberties in their calculations each year of medical expense and benefit costs and what the prices are for them when they submit their benefits and their bids to compete around the country. And again, MA actuarial filings are an art, not a science. So all of this is done to really ensure that MA plans remain competitive in given markets and aren't disadvantaged in many ways. They may have lower risk adjustment revenue. They may have lower star scores and bonus dollars. Their provider agreements may not be as good as some others, but some of this actuarial tweaking allows them to try and offer as best a benefit as they can in a given market. Obviously, this can only go so far, but nonetheless, this is sort of part of the game in the MA world. And this is fairly easy to do in good revenue times. If your revenue is very high, you can take greater chances and make some things up elsewhere. But when revenue times are a little more difficult, like in a much tighter rate environment that we're seeing now, it's a lot tougher on plans when they do this. So again, we saw sizable rate increases and generous star scores earlier in the decade, and that really meant plans expanded benefits and footprints very dramatically. When star scores began being recalculated without the COVID flexibilities in 23 and into 24 with some other changes that came in on weighting and taking outliers out of star calculations, we saw some plans begin to ratchet down benefits, so-called reprice them, and even their footprints geographically. With the 24 rate contraction and continued star impacts, that kept happening. And that's really what Broussard is referring to here. Broussard said in his investor relations call that because of some negative changes, and by the way, Humana did very well by and large on star scores, but because of the rate contraction, they thought it was important to contract some benefits and the amount of PMPM cost that was being sent back to members in added benefits. So they contracted benefits a bit. Another good example of a plan that had done so is way back in early 23, Centene had announced that it was repricing and pulling back in certain geographic areas due to their low star scores and in an effort to rebalance and get back to very good profitability in their MA world. And other plans definitely have done this too. So what Broussard is basically saying here when he talks about repricing is that what is already occurring in the market by pulling back in benefits as well as geographies will perhaps continue. And more importantly, it could continue at a greater degree than we've already seen it. And right now, the impact isn't being felt really hugely by beneficiaries because we had such an upswing in benefit offering and expansion around the country. But if we are seeing this lower revenue because of various reasons and higher medical expense, Broussard is basically saying that the entire industry may have to accelerate its retrenchment, so to speak, both on the benefit side and potentially on geographies served. And there are other warning signs out there that could make it even worse. I talked about the RADV rule and what that impact could be, as well as the prior authorization rule. So what does this really mean to the consumer if we do have this repricing out there? So as I said, plans will be forced to pull back in benefit generosity as well as their footprints. Um, Long-term revenue prospects will not justify the cost of the additional benefits offered, and plans will be forced to do a couple of things. One, increase premiums, reduce the savings against fee-for-service that their members get on cost sharing. There is a lot of reduction of cost sharing from the fee-for-service program that generally occurs in MA, and also a reduction in the so-called supplemental benefits that plans have been able to build into benefit packages as well. So dental, vision, hearing, cards that allow you to cover some of your costs of rent and groceries, as well as OTC benefits. All of these things could contract in the future. And again, given the new prior auth rule, which I think now you've learned that I absolutely hate because I think it's going to have profound effect, it's very likely that MA plans will no longer be able to offer a significant additional benefit that essentially reduces or eliminates the inpatient days cap in the fee-for-service program and reduces cost sharing for those hospital stays. And I say that's a real shame because this is an important safeguard for low and lower middle class fixed income folks who are constantly battling huge bills for that inpatient days cap or the very high cost sharing that occurs in the fee-for-service inpatient benefit. So those are the kind of things that could occur in the future if Broussard is right. Does this mean that MA is in trouble? Well, Broussard would lead you to believe that there's certainly some warning signs out there. At the same time, he says MA is the place to be and doesn't believe he wants to leave it. So he's both giving a admonition about what could occur down the road, but also sending a signal that MA is still a good place to be. But I will note that there are some market signs that say that MA may not be the greatest place to be. I don't tend to believe it, but we have to take this other information into consideration as well. Here are three examples. So the Moody's Investor Services, a bond rater and financial firm, just concluded a study on MA profitability. And just as brief background, I often say that an MA plan should be able to earn a margin of between 4 and 6%, depending on how well run it is. But what Moody's found is that MA profitability between 2019 and 2022 dropped considerably. It looked at 10 players covering about 2/3 of enrollees and found that profitability dropped from 4.9% in 2019, within that range I often talk about, to about 3.4% in 2022. So that's a material decrease. And that does not even get to the 2023 and 2024 years where rate hikes were very tight. I'd also note that David Cordani, the CEO of Cigna, has a very different view than Bruce Broussard. Originally, Cordani was looking to actually merge with Humana, and that would have created a all lines of business powerhouse, strong commercial in Cigna, growing Medicaid in Humana, and a very strong Medicare portfolio at Humana. But when that fell through, and even before, Cordani was looking to shed his almost 600,000 MA lives. And originally that was to essentially pass antitrust muster. But Cordani now, even though the Humana and Cigna merger fell through, has just announced a sale of those MA lives to Healthcare Services Corporation, a Midwest Blues plan, which was dying to get a hold of more lives. Today it has about 200,000 lives. With the Cigna lives, it will be up around 800,000 and be very, very large. Now, Cordani got rid of MA because he was having some financial performance issues in MA, also star issues, poor star showing, and enrollment was up and down, and they never quite mastered it. So Cordani came to the conclusion that MA wasn't the place for him to be, and he wants to focus on core commercial insurance as well as his growing Evernorth services business. So another example of a warning sign. I would also note that when Molina closes or has closed, depending on when you're listening to this, on the Bright Health Lives, it was announced that the amount of money that Bright gets for those MA lives came down considerably by at least $100 million, and it could be as much as $200 million, depending on how much of a contingency has to be used. So there's another point in the market that says the value of MA lives appear to be coming down. Part of that could be related to how Bright Health ran the business, admittedly, but part of it could also be due to some of these trends we're talking about. But let's get back to the issue: is MA in trouble, and will MA somehow go away? Well, I think that MA is not really in trouble because there's one clear fact here. It's not going to go away. It's going to have to adjust, is what I would say. And that clear fact is the fact that MA is much better than traditional fee-for-service. Critics can talk all they want about the negatives of MA, but the alternative is the dilapidated fee-for-service system, which has benefit gaps and huge costs for consumers. So MA has lowered the cost of delivering those traditional services historically. They've added additional benefits and protections, as I've said, and it's thrived because of great value proposition to consumers. That's why we saw roughly a 40% growth, or about 9.5 million people since January 2020. But in the end, based on what is happening, MA will likely look very different. It will have to, as I say, adjust. It won't implode. It will have a rough ride. It will have to adjust. The boom times are gone. So with the margin softening, that will, it appears, continue into the future. And again, the boom is over. I would argue that what will happen here is really what Brassard is talking about. Over the next several years, to satisfy investors' demands for strong margins and multiples, that these publicly traded plans, as well as probably many others and perhaps all others, will have to pull back on those benefits year by year, and even some geographic areas that aren't as profitable to lower risk and meet investor demands. So over time, margins will return to what they need to be for investors in MA, although getting back to those investor expectations could take a great deal of time for sure. People will still be attracted to MA because, again, there will continue to be added value over fee-for-service. But to me, the real sad fact here is that Capitol Hill lawmakers, really on a bipartisan basis, and CMS and MedPAC and many others, are essentially driving up costs in the program for bad political rather than good policy reasons. Progressive Democrats probably want to achieve their dream of Medicare for all. Other Democrats and Republicans, to me, are simply currying favor with providers and are simply not aware of the long-term consequences. I'm the first to admit that we do need some reforms in MA, but what is occurring is way too far out there and over the edge. You can take each individual change and say, perhaps not the prior auth change, but other changes that they may have some merit and may not be cataclysmic to the industry as a whole. But if you take them all together in a already very heavily regulated and accountable space, which is MA, you are playing with fire here. and the necessary repricing and retrenchment that plans are going to have to do will really mean two things. One, it will rob the lower and lower middle class of critical benefits and protections, and that pain will be real. And it will also rob the Medicare health space of innovation by the private sector. Inevitably, what will happen is that lawmakers and even CMS will blame greedy insurers, as an example, for what's happened in terms of benefits and higher costs on consumers. And they certainly won't tell them that they themselves set the stage for these benefit reductions. Democrats might argue that for-profit companies do not belong in healthcare. But if you really go back and look at the traditional fee-for-service program and examine it, you'll find a complex maze of confusion, high cost, fraud, waste, abuse, and poor quality. And you ultimately still have to come to the conclusion that the real alternative to fix Medicare proper would be accountable reforms to Medicare Advantage, not what's occurring here. And you certainly want to save the value that MA brings to consumers. And you'd also have to conclude, based on the fee-for-service program, that government-run healthcare in America simply does not work. So I hope lawmakers and CMS wake up before too much damage is really done here. And ultimately, I think that's what Broussard's swan song message as he looks to retirement later this year was all about. So the question is, does it have to be this way? Do we have to see a permanent re-benchmarking or retrenchment or repricing within the MA industry? Well, I think at least in the short term, you are going to see it. If I go back to this new prior authorization rule, I do believe that it will have a fundamental chilling effect on the MA industry. I think some plans are going to try to get cute with CMS and try to argue that NCDs and LCDs aren't really that directive in terms of what to do in certain cases. But I think the fact that CMS is going in and auditing plans immediately, even beginning in January, on the new rule and plans compliance with it, sends a message that for whatever reason, and I think it's insanely political and disturbing, that CMS wants this fundamental change in prior authorization. And I think Humana has called it right, that CMS is going to be entirely forceful on this. And because of that, PA will be chilled in MA, and we will see major cost increases initially, which will necessitate over the next several years that retrenchment that Broussard talks about. Down the road, however, I think MA can get back to where it was to have strong benefits and an exceedingly strong value proposition. But it means a fundamental pivot from utilization management and prior auth to a brand new paradigm. And how do I think about that paradigm? Well, overall, I think about it as investing in data infrastructure and the ability to have really strong data analytics. And so we'll have to see infrastructure investments that will bring data together, clean it, transform it, make sure that it's complete across the health plan enterprise, so that that data then can be analyzed and sent to various units, to various providers, and also to members to look at the cost of care and to change patterns and things of that nature. So that investment in data infrastructure and analytics is absolutely key. What exactly do I mean by analytics? Well, think about the fact that most of a plan's effort today really goes into a PAUM infrastructure, which is a gate that is put up before costly services are obtained. And again, I believe that has a place in managed care and in healthcare in general. But you can also make a case that with real-time data that is analyzable, that you can intervene in care as it's happening and over the long term to stop expensive events like inpatient hospitalization and other types of costs related to disease and morbidity and things like that. And so if you pivot to analyzing data and changing member behavior and provider behavior, you are able to essentially save as much or greater costs than in a UMPA dominated environment. So let me give you a couple of cases and points here. We know that using the right site of care is absolutely essential to save. We have hospitals and providers that are owned by hospitals forcing people to go to a very expensive site of care for procedures that actually can be done in the provider's office or in an ambulatory surgery setting at much less cost. If we can get data together to determine patterns of sites of care at the health plan level, at the product level, at the provider and provider group level, and educate providers and members about right sites of care, a lot of dollars can be saved. Another example would be leveraging admission, discharge, and transfer information that is available from hospitals and health information exchanges and clearinghouses within the health plan to basically intervene and ensure that transitions of care is done. That will get people out of the hospital earlier, and that will also prevent readmissions. So just two examples of how data analytics can be leveraged as sort of a substitute for that upfront PA process if it really is going to be fundamentally changed. Next, beyond that transformation of data and infrastructure is sort of a pivot from to care management. We need to emphasize wellness, prevention, and care management. Historically, plans have been reticent to do this because tenure in plans was a lot shorter and they could not derive immediate value. But with tenure in health plans getting longer now and the necessity of improving quality for revenue and star scores and things like that, a pivot to wellness and prevention and monitoring individuals and intervening in disease states and, for example, preventing hospital admissions for preventable conditions related to the worsening of disease states are areas that we really need to invest in. Again, we've emphasized the and the PA, but not the care management components. I will also say that monitoring social determinant barriers or social determinant of health are very important as well in many populations, especially Medicaid and Medicare. Sometimes these barriers can be greater determinants of cost than their underlying disease states. So combining SDOHs with good care management monitoring of conditions will be very important and prove a huge cost saver along the way. And then lastly, I would note member and provider engagement. So plans need to invest in digital health and other ways of communicating with members and providers. Members need to take a stake in their healthcare. They need to understand the right site of care for deciding where a procedure is going to be done, what they need to do on the wellness and prevention front, what they need to do on disease maintenance. In the case of providers, capitation and global and partial fund reimbursement is becoming very, very popular, and engaging the provider with analyzed data about ways that they can intervene in member care and how that will improve the bottom line in their global and partial funds is also extremely important. I've talked a lot about cost here and how we need to fundamentally rethink on the basis of cost. But these same kinds of approaches to data analytics and digital health and things like that can also be used to increase revenue and increase quality. Obviously, the more you talk about wellness and prevention, the more care gaps are going to be closed in quality. The more we monitor and identify disease states, the more opportunities there will be to identify diagnoses that should give you more reimbursement based on risk adjustment, as well as help you document and protect plans in this new risk adjustment data validation world, at least in MA, and what may roll out in other areas as well. So a case can really be made, as I've said, that savings in these areas, investments in digital health and care management, in transforming data, can actually save more dollars than what the PMUM enterprise did. Again, the plan should fight to save some forms of PA and UM because I believe it's a necessary part of managed care. But at the same time, the attacks on the PA front give MA plans the opportunity to, as I said, pivot to these other areas that hold greater promise, perhaps in reducing costs, improving quality, driving revenue, and transforming our healthcare system. And it may be the recipe, this clean and timely data and analytics may be the recipe to get these insurers back to the margins and multiples that investors ultimately will want to see. With that, I'll conclude this edition of the podcast, and we'll see you on the next Healthcare Labyrinth podcast. Take care.